Well, we're going to get started. We'd love to stay on time. First of all, welcome to everybody. It is so nice to see the senior nursing students, a lot of members from our community joining us, and all the nursing staff and everyone else. We have these integrative medicine lectures every other month from September to May. So we're gearing up again for our next series in September. So please let us know if you'd like to be on our mailing list. We'll send you an email prior to, and all of the notifications also go through nursing. But we have a lot of fabulous topics every other month within the integrative medicine and a lot of other educational programs that you might enjoy. I am so delighted that we could get, Dr. Kumar to speak for us, and two, that we could track her down and reserve her. She is not only our Moffitt expert on botanicals and natural products, but she's also an international expert who travels the world speaking on this topic. She has brought a lot of reputation to Moffitt because of all of her expertise. She's a senior member here in population sciences at the Moffitt Cancer Center and a professor in oncologic sciences at USF. She's a registered dietitian and a fellow of the American Dietetic Association. She has been in clinical nutrition practice for 33 years. She was one of the founding directors in 1986 of the nutrition program here at Moffitt and directed that program for 20 years. She's funded by the National Institute of Health, the National Cancer Institute. And her group here focuses research on examining the role of nutrition and other lifestyle factors in prevention, treatment, and survival from cancer. I was just informed she's also going to be representing the National Cancer Institute of NIH in an international consortium where she will go to China and help teach others how to evaluate botanicals on behalf of our National Cancer Institute. So it is such an honor, one, to have Dr. Kumar at Moffitt, and two, to have her with us here today. So please join me in welcoming her. Thank you.
Thank you, Sarah.
Okay.
Thank you. Hi. Good morning, everyone. And I have a lot to say. I mean, a lot was said, and I hope I can live up to it sometime in the future. Thank you all for coming today. In the next 40 minutes or so, I'm going to try to summarize our approach and our rationale as to why we think nutrients and nutrient-derived compounds have something to do with cancer prevention and how they aid in the treatment of cancer and potentially also in the survival of cancer. We've been pretty snobbish about our approach. We are not looking at the newspapers every day and looking at what's good, what's not good today, and what's good tomorrow. But we've been very strict about following a very strict scientific approach in how we are going about systematically developing these compounds and really evaluating them for not only effectiveness in prevention, treatment, or survival from cancer, but also safety, which is very important. So our theme, our group has been working on 3 different themes. One is looking at contribution of body composition, body fat, obesity, and the hormonal implications of obesity and body composition, body fat distribution as it relates to cancer. The second area that we've been focusing on is the role of nutrients, nutrient-derived agents, and other non-toxic agents in cancer chemoprevention, treatment, and survival. And while doing this, we've also been very sensitive to the disparity in cancer incidences and responses to treatment in specific subgroups. So we are also focused on cancer disparity while we study these kind of etiology and treatment and survival from cancer. And I always say this, most chronic diseases, including cancer, result from genetic endowment. social and environmental conditions, including some good things that we know, some of the recent advances in medicine, but most importantly, individual behaviors. And we've known this for some time, and that's why people like me have jobs to do. And this old slide is from 1982. And if you look at the causes of cancer, and this was published by Doll and Pito, who were great epidemiologists of their time. And if you look at the tobacco, adult diet, obesity, sedentary lifestyle, all this still holds true. Like almost 65% of cancers are preventable just based on individual behaviors. I mean, tobacco, easy to control. Adult diet, obesity, I wouldn't say any of it is easy to control, but they're all controllable factors that cause cancer. And we still blame it on environmental pollution. We worry about what's sprayed on our little apples, things like that, where it's, in fact, almost 65% are things that we do every day that can prevent cancer. And this is not the original slides from 1942. One of the earliest studies that showed the relationship between nutrition and cancer came from a group by the name of Dr. Tannenbaum and Associates in the 1940s, in the early 1940s, where they fed a group of mice corn oil and the other group of mouse rat fodder, the regular typical rat fodder. And they found that the mice that got the corn oil developed spontaneous mammary tumors that were not only spontaneous, but they were also resistant and virulent and resistant to treatment. So this was the first inclination that we got that there was some relationship between dietary fat and mammary tumors or hormone-related cancers. The next group of studies came from epidemiologists like Doll and Pito, where they looked at nutritional consumption of plant foods, dairy, and other fats, and they saw very significant comparisons. And literally every graph went the same way. The higher the intake of dietary fat, the higher the incidence of prostate cancer, the higher the risk for breast cancer and colorectal cancer. And what they also saw was this combination that the higher the fat and lower the plant food diet or plant foods coming from whole grains and vegetables and fruits, that combination was the worst, which is what was typically seen in the Western world. So this was the next group of studies that showed that something in the environment or something that we're doing in our lifestyle has to do with risk for these cancers that are potentially preventable. The next group of studies came from migration studies. These group of studies were done by University of Hawaii. They continue to do this work, very elegant studies where they showed that Japanese in Japan, compared to Japanese in Hawaii, compared to US Caucasians, look at the colon cancer rates, look at the rectal cancer rates or breast cancer rates, all approaching similar rates of that of the US population. Again, these were also, this increased the kind of evidence that migrant populations acquire the rates of risk, which was very similar to the environment they came to live in. And more evidence, Japanese in Japan, Hawaii first generation, it increased, but look at the Hawaii second generation. Even the height of Japanese, the weight of Japanese adolescents are equal now to American adolescents. And also within U.S. populations, secular trends, Seventh-day Adventists in the U.S., vegetarian, no pork, have 50% lower mortality rate from breast cancer and lower cancer rates and also cardiovascular disease rates. And we also see differences in African American populations, either migrant or otherwise. Even among African Americans, there's a significant disparity. Extremely high rates of prostate cancer in places like Jamaica, whereas very low cancer rates in places like Nigeria, and somewhere in between the African Americans living in the U.S. So there's and the differences in nutritional intake as well as genetic predisposition is very significantly different in these three populations. And what do we know about the biological plausibility? And here again, this is an area where we've worked on for the past decade or a little more than that, where we know that the obesity rates in the US is an epidemic now. This is in 1992. All the red areas that you see there, over 30% of the population, I mean, you don't see red yet, you'll see in the future. In the dark blue, over 20% of that population, or close to 20% of the population in those states were considered obese. And then you see the yellows now appearing, over 20 to 24% of those states are obese. And here comes the red. And you see the lighter red is about 30% of the population is obese, whereas the darker red, over 30% of those populations in those states are considered obese. And this is in 2005. And look at 2009. It's getting worse. So we are really in an epidemic where obesity is rampant throughout the entire states of the USA. And look at the disease risks or consequences of obesity, hypertension, and everything else, including breast and endometrial cancer. We have also shown that more than obesity in general itself, as it pertains to cancers, progressive weight gain during adulthood is also the culprit. You know, whenever I show this picture, people always say, well, that's my daughter, that's me, and that's my mom. And, you know, and it's typically what we see very significant. And what we saw in our earlier studies is the weight gain in adulthood is predominantly in the abdominal region, which is the culprit again. And I call that, you know, we call that the apple shape versus the pear shape. Pear shape is typically how women gain weight during puberty. But then the pear shape, which is the which causes perturbations in several of the steroid hormones, was one of the contributing factors to increasing the risk of breast cancer as well as endometrial cancer. This was, we published this in the 90s, actually. When I show this picture, people usually tell me, but I've been a banana all my life, what's my risk estimation? So I think I'd call it android versus gynoid kind of body fat distribution. This is important as a culprit. I call this the perils of portliness, or consequences of that kind of an android obesity. We found that breast cancer risk increased 5-fold in this population, endometrial cancer risk. When I was doing the study, we had some 30 or so patients eliminated because we could not even measure the body composition, abdominal obesity with the calipers that we were using because it was so high in endometrial cancer patients, and of course several others. And we also found that the culprit here was the adult weight gain, the weight gain at age 30. And there are several potential mechanisms that we proposed. This is again a work in progress. We think it works through the steroid hormone pathway, but you know, with all the new discoveries that we're making over the years, I think this is still up in the air. But for some reason, obesity and abdominal obesity especially, we find is a culprit. And yet, we have a society where there's a real portion distortion. And I always say this, and I'm sure I'm going to get sued one day. We can eat a 32-ounce steak and get our names on the wall of a restaurant, right? So it's really a problem. And I think it's not only what we are eating, it's also how much we are eating. And we really have an issue with portion distortion, which increases caloric intake, which increases fat intake. And if it increases fat intake or even carbohydrate intake, it's going to increase the chances of obesity. And the next area we know, the biological plausibility area we know, is the known benefits of physical activity. I mean, we're not Homo sapiens anymore, we are Homo sedentarians. We use a remote for everything. I was just asking the AV person, can he remotely get me hooked up on in CPC2 across the street so I can do my next presentation. And he said he could, so we can remotely do everything. But definitely there's some connection between balancing caloric intake, and I think it may work indirectly to decrease risk of cancer by indirectly balancing the intake output of caloric intake and fat intake. So physical activity, there's not a direct correlation yet, but it somehow reduces the amount of fat depots that we have if we are physically fit. And of course, there are so many other cardiovascular benefits to physical activity, but this is also a very hot topic in cancer prevention, not only in cancer prevention, to prevent treatment-related fatigue and also now for cognitive impairment in cancer survivors, especially childhood cancer survivors. So physical activity, you're going to hear more about the buzz about this area shortly. And yet, look at the population that is in dark blue, 32.6% of that population. And you saw, if you can lay this graph over the obesity graph, it almost looks alike. That's inactivity. 32.6% of that population is inactive. And so pretty much, other than this part of the world, that side of the country is basically over a third of them are inactive. And the last but not least area where we are very excited about is looking at nutrients that can modulate the risk of cancer. And prevention is the ultimate approach to controlling cancer. We know that. And what is cancer chemoprevention is that it's a prevention of induction and inhibition of the development of pre-invasive or invasive cancer and its progression, or treatment of identifiable precancers. And this can, we know that cancer doesn't happen overnight, so we know that we can interfere in this process throughout our lifetime, and more recent studies have shown that many of these processes can be modulated. And that's why I said, yes, maybe it is a genetic disease, but we can modulate it by individual behaviors. So these substances that are nutrient-derived are anti-promotion or anti-progression agents. See, by now I'm calling them agents because now we're developing them into these serious compounds that can potentially be drugs for the prevention of cancer or for the treatment of cancer, and it comes from the food that we eat that can prevent the growth and survival of cells already committed to becoming malignant. And what is the promise? Prevention efforts require a thorough understanding of the mechanism of how these cancers are formed or the process of carcinogenesis. The knowledge of a molecular basis of carcinogenesis is critical, and you have to know what these nutrients are actually doing before you start treating patients and saying we are going to prevent cancer for you. So it's very important to know that. It's important to know the metabolic pathways as well as the genetic progression models. New technologies in genomics and proteomics have spurred this field of research. So we are in a very exciting time where we're all working together and getting our heads together to solve this puzzle. The use of this knowledge to develop pharmacological agents, including nutrients, to reverse or halt carcinogenesis is called the area of chemoprevention. And, if you've already heard me say this before, this is how I understand how important nutrients are in chemoprevention, or in how we are impacting or reversing the process of carcinogenesis. And it's from our knowledge of what we know about what happens to cells in our body. And we know we all have a gazillion cells. Several of them are already committed to becoming malignant, but they all get reversed and get thrown off. But the conditions have to be ideal for those cells to become cancers. And how do they become cancers? We know that a cell typically should, I'm sure I have a, cells should typically mature, differentiate, which means it should act like the cells that it's supposed to act like. If it's a renal cell, it has to act like a renal cell. So it should act like the cells a group of cells that it belongs to. And eventually the cells die off, and it's a term apoptosis, and new cells are formed. And this cycle is a normal cell cycle. However, if the cell undergoes what is called mutagenesis, I call that cells going rowdy. It can either happen from your genetic makeup, or it can happen due to external factors, and that's what we are talking about, the steroid hormonal values that we're talking about, the sunlight, the other things in the environment that can cause mutagenesis. Cigarette smoke is one of them. Then the cells go rowdy and start proliferating purposelessly. And so they form their own kingdom with their own rules, and that's how cancers are formed. It may sound very easy, but that's how I understand it, like a cartoon. And so what we are looking at in looking at nutrients in cancer chemoprevention is looking for those substances that can decrease this opportunity, increase this opportunity of cell cycle regulation, of cells maturing, differentiating, dying off, this natural process, and preventing this process from happening. We also know inflammation can be mutagenic to certain groups of cells and can cause this rowdiness to happen. So we're looking at nutrients as agents that can reduce this, and improve this, and improve this. And that is the rationale with which we are going about finding nutrients as chemopreventive agents. We also know that cancers don't occur overnight, that it's a very long process. For example, in prostate cancer, it takes about 20 years from this point to this point. So we know we can interfere in these processes, and these cells can be reversed. These processes can be reversed. More and more studies are showing that nutrients in appropriate quantities at appropriate timing can reverse these processes. And we know from epidemiological evidence, the epidemiologists give us the direction as to where to go, what are the nutrients that are looking promising, what are the nutrients that can benefit to reduce risk of cancer, or group of nutrients. And so we know that dietary factors used alone or in combination impact occurrence of cancer, metastatic progression, as well as treatment of cancer, and may be able to produce chemotherapeutic effects with a relatively low toxicity compared to other agents like tamoxifen, PS341 drugs that are all known for preventing certain cancers but have high toxicity. We know that they hit multiple targets, and I know many of you are not biology majors, so I'm just going to go through this very quickly, that we know that nutrients can, remember I was saying that we should know the mechanism by which these nutrients impact the carcinogenesis process or the cancer process, and we know that it affects several nutrients, or over 100 of them now in the formulary at the chemoprevention branch at NCI. We know alone or in combination can impact all these functions or all these pathways that are implicated in carcinogenesis. So simply put, nutraceuticals or nutrients developed as agents for chemoprevention or treatment can affect cell proliferation, cell survival, inflammation, metastasis, angiogenesis, invasion, all of which are critical in the process of carcinogenesis. So we know that now. And some of the nutrients that we've been interested in, this is what I call my short list, are soy isoflavones, carotenoids, lycopene and beta-carotene, green tea polyphenols, calcium, indole-3 carbanols. This is found in cruciferous vegetables, curcumin, the yellow powder that's a component of curry powder, allylic sulfides, garlic, onion, the stinky part of garlic, And again, I'm fascinated by the people who buy hundreds of dollars worth of garlic capsules without the smell, but the potent agent in garlic is the allium, which smells. So you're buying the shell, you're paying a lot for nothing. Folate, not only colon, but also cervical and other epithelial cancers, tannic acid, a lot of good in vitro work coming out, omega-3 fatty acids. I think this is going to be the buzzword of the 21st century, resveratrol, anthocyanins, and I'll touch on all of these in the next few slides. However, even though we know so much about plant foods and their benefits, and like I said, I showed you only a short list of the botanicals that are currently under investigation for safety and efficacy for prevention of cancer, treatment of cancer, and survival, more than 50 states, in about 50 states, not even a third of adults consume 2 or more fruits a day, or fruits or vegetables a day. So that's a huge problem. Even though we know all this, we know about the benefits of plant food, not only in cancer prevention, but also in cardiovascular disease prevention, in diabetes or type 2 diabetes prevention, all the major diseases. Potato is still the #1 vegetable of choice, and the fact is it's not even a vegetable, it's a starch. And vegetables were also cooked in high-fat meats, with high-fat meats, and we, of course, consume more processed grain than any other part of the world, and we spend the most on laxatives, and diverticulosis is of the, I see people can actually relate to this. So where do we go from here? It's really not all gloom and doom. We have a very systematic approach, as I said, right at the beginning, of evaluating these nutrients as agents for prevention, treatment, as well as survival. First of all, we have understood that we have to have the organization to do it, a symbiotic relationship between academia, pharma, and biotech. They're good at what they do, and we're good at coming up with the ideas, right? So it's very important to work very closely with them. We also clearly understand that this is a multidisciplinary effort. I'll show you my last slide, which has everyone who's a part of one trial, and you'll see why. And most importantly, we have to know the biology of the disease risk and progression, and the latency. How long does it take for this carcinogenesis to occur? In pancreatic, it may be a much shorter time. In prostate, it's the other end. It takes 20 years. The latency period is much longer. We need to have a thorough knowledge of the molecular basis of carcinogenesis. It's that complicated slide that I showed you. We know a lot of the targets that it hits. And one of the fascinating things about nutrients is it's not one nutrient and one pathway that it's hitting, like a typical drug that's developed pharmacologically. These nutrients have multiple targets, so they hit multiple pathways at the same time, which is a great benefit, because if one fails, the other one may work. And then again, most of these are not, they are safe to use. And we also have to know what we are intervening with. What are we, if it's a traditional Chinese herbal medicine, the average number of herbs per mixture is about 9 or 10. So 9 agents targeting one cancer. It's kind of complicated, but we need to know the characteristics. Whereas if it's a lycopene or if it's a beta-carotene, we know the characteristics of these agents. We know the chemistry. We know we can get standardized preparations, unlike the garlic preparation I was talking about. Whether it has to be a whole agent or whether it has to occur singly. A good example of that is isoflavones. Isoflavones and also green tea polyphenols. Green tea polyphenols occur as a group of catechins, but the most potent of those catechins in green tea polyphenols is one of them. It's just one of them. But if you just gave that, it doesn't even get absorbed in the GI tract. So it's important to, but if you give it to an individual as the entire component, as a green tea polyphenol capsule, then it gets absorbed. So there is some kind of a synergistic value to some of the components that occur in nature. that makes it more biologically available. So it's very important. Bioavailability is important. And is it really hitting the relevant targets? So you can't take something that's going to work for pancreatic cancer and give it to prostate cancer, because they're two different cancers and it may not work. The molecular pathways are different and it may not work. So it's important for us to know the relevant targets. Safety, very critical. Just because it's a nutrient, you can't think it's safe. You have to test it to make sure it's safe, because you're giving it with utmost potency, especially when you're giving it in the form of a tablet or a capsule, a standardized form, and not as if you're feeding somebody a box of grapes or a container of blueberries. You're actually giving them 14 containers of blueberries in a capsule. So it's very important that you test the safety. You have to know the contraindications and concurrent use of other medications. For example, if you're giving someone 60 or 80 milligrams of isoflavones, which are purified, and they're already on tamoxifen, that's a contraindication because it has very similar pathways that it targets. So concurrent use is not permitted. A duration of intervention is also important. Like, you can't give somebody who has prostate cancer 3 months of a drug and look at efficacy, because it's not going to happen in 3 months. So that's very important. Unless you're giving it at a very high dose and you're giving it to somebody who already has cancer, you can't test it very well. And intermediate endpoint biomarkers. Like I said, things take 20 years to progress to cancer. So you can't do studies where you're giving the drug and waiting for 20 years to see whether the patient really got cancer or not. So it's important to identify valid intermediate endpoint biomarkers that are indicative not only molecularly, but also clinically relevant intermediate endpoint biomarkers that make sense, that show that, yes, this agent has promised to prevent the disease. And also, we should know as I said, our approach has been thorough. We know the molecular basis of all the agents that we are working with. At least we know the major molecular pathways. We follow a very ethical, rigorous method with which we test other drugs. So we are doing phase 1, phase 2, phase 3 clinical trials. It has to be systematic. It should be informed by epidemiology, by preclinical work or animal studies. Do it in vitro and then go to phase 1 for safety, phase 2 for safety and efficacy, and then the full-blown clinical trial that then goes to form a standard therapy to prevent or treat or treat a symptom of cancer. And translational studies to test safety, effectiveness are also very important. And I always say we have to come up with alternate approaches, because these natural food compounds are more complex than we think they are. So we have to think about alternate approaches and alternate mechanisms also. So I'm going to go through, I think the clock stopped, so if you can give me how many minutes I have, I can go quickly. Or I'm not seeing? Okay. So I'm going to give you some examples, 3 examples of one prevention trial using a nutrient, one treatment trial using a nutrient, and a survival trial using a nutrient. And these all 3 studies are done by our group. We are looking at an agent which is made up of the green tea, derived from green tea polyphenols, and I'll talk a little bit about that. We have some very good evidence, very elegant studies done in epidemiology that show a protective effect of tea consumption against human cancers of the breast, cervix, colon, rectum, and also includes prostate cancer. And so this was studies done comparing Japanese, Chinese versus Caucasian populations, Japanese, Chinese, where they consume a significant high amount of green tea, almost consistently all day. And then we also had very good evidence from animal studies, from Gupta's group, Niska's group, and this from Dr. Gupta also, and some of our work that we just completed recently that showed that polyphenolic compounds can prevent the progression and metastatic progression also of the disease. Not only prevent, but also prevent progression of prostate cancer once it has occurred. Evidence from in vitro work. This work was done by our lab, our drug discovery labs. This is where we saw that EGCG is one of the most potent catechins. And what showed us that even though EGCG was the most potent catechin in green tea polyphenol, we saw that the EGCG given alone, and this was the group that discovered that it had relatively low oral bioavailability, and which is like a goner for us in clinical trials, right? If it's not bioavailable, what's the point? So that's why it was important to make a preparation or the formulation that had exactly what green tea polyphenols had, as you would drink in a green tea beverage. Another important factor that came out of this is it's very important to get a human equivalent of the dose to work. You can't give 14, 15 times. Like I was saying, you can't give stuff, even though it's a nutrient, in such large quantities in animal studies that can never be translated to a human clinical trial. So it's very important that we are realistic about the doses we use. So these studies inform our clinical trials immensely. So from the in vitro work, we kind of knew the pathways that it was targeting, not only from our group, but also from other groups around the country. So we knew the molecular targets of green tea polyphenols, and they were very potent, as potent as PS341 drugs, which are used to prevent prostate cancer and for prostate cancer progression in high-risk populations. But we saw similar effects, but with no toxicity in phase 1 clinical trials. So these are some of the studies that were ongoing and are still ongoing using the polyphenol E, which is the catechin that was developed, which is a mixture that we're continuing to test in vitro. And evidence from clinical trials. So, okay, it works in animals, it works in the Petri dishes, and epidemiology has already shown us that these populations have low incidence of cancer. How do we take it to clinical trials? So some of the first phase 1 trials were done at University of Arizona by Dr. Chow et al., where they looked at different doses of EGCG and in healthy population and saw that it was safe up to about even 1,200 milligrams a day. And they used the same agent that we are using currently. We also had another group out of Italy that took 60 subjects and administered something very similar to the catechins we're using, and they took the high-risk population of men who already had a precursor of prostate cancer, the men with high-grade PIN, and saw that, very, very significant results to the point where almost no one believed them, which is good because that's why we got funded to do this study. And no significant effects were documented, and they also had lower urinary tract symptoms. So it's always good to build in not only efficacy to prevent cancer, but also you don't want to have other side effects and other symptoms. If it can lower urinary tract symptoms, that's even better in this population. So we came up with this schema that this polyphenol E at the lowest dose, there again we are very conservative about how, even 1,200 milligrams is safe, but if you're going to prevent a disease that's latency is 20 years, then it's important to go with a lower dose than with a higher dose and create toxicity, and then it'll be thrown out the window, just like selenium was or vitamin E was. So we knew what it does molecularly. What the molecular target is. I-kappa B alpha is a huge culprit, and it has been implicated in inflammation, proliferation, angiogenesis, several pathways in the carcinogenesis pathways. So we know we were impacting, NF-kappa B. I-kappa B is opposite. NF-kappa B is the culprit. So we knew we could decrease that, inhibit prostate cancer survival, induct apoptosis. Remember the good cell cycle I was talking about, decrease prostate cell proliferation, and reduce and prevent progression from this precursor stage to prostate cancer. So our outcome is prostate cancer progression. Our intervention is going to be, our objective is to assess the rate of progression, evaluate the safety of the agent, and also validate the molecular pathways that we already looked at in vitro in the Petri dish studies that we did. It's a multi-center trial. 9 sites have been included. Actually, that's the meeting I'm going to after this. We have our multi-center trial PIs meeting today and tomorrow. We're talking, the main thing we want to do is establish safety, tolerability, and efficacy of this regimen. Subjects are randomized to one of 2 groups. One group will get this. The other arm will get the placebo, and the duration of intervention is 12 months per subject. And the duration of the study is 5 years. This is still ongoing. Here I have an example of a treatment trial, which I'm sure some of you nurses will be interested in this treatment trial. Many of you are part of this trial. Cachexia, we know. In my 33 years of treating cachexia, I don't think we've succeeded. It's the same. It gets always mixed up with cancer anorexia. But cancer cachexia, we know, is a completely different disease from cancer anorexia. Anorexia is one of the symptoms. It's a pathological state where loss of muscle and fat occurs, manifested by this cardinal symptom of emaciation, weakness, affecting functional status, impaired immune system, and metabolic function. No traditional feeding methods or appetite stimulation methods help cancer cachexia. We know that. Cancer cachexia occurs in 50 to 80% of cancer patients. 80% is more like lung and pancreatic. 50 is all others. Independent predictor of shorter survival, increased risk of treatment failure and toxicity in this population. It is non-responsive to traditional treatment approaches. We've fed them with as much Ensure as possible, and all of you are nodding here. Nothing works, and we know that, and the mechanism is very poorly understood. So we kind of cleaned the slate, and we said, now let's use the same approach we are using in our prevention trials to see whether we can look at agents that target this proteolysis and lipolysis that we see in cancer cachexia. What is it? Is it an inflammatory disorder? Is it a disorder that's propagated by this culprit, the NF-kappa B that I was talking about? So we wanted to try to explore the mechanism of action. And lo and behold, we found that omega-3 fatty acids has been looked at already, but the mechanism was never understood of how omega-3 targets NF-kappa B and reduces, downregulates NF-kappa B. So it was very important for us to do those studies from scratch, and we saw that both in animal models as well as in vitro, omega-3 fatty acids, the EPA and other omega-3 fatty acids can reduce this protein degradation by downregulating this NF-kappa B. So we thought, and all the clinical trials done before were done in metastatic pancreatic cancer patients who had a very short duration of survival. And they did it, and so it failed. So they threw omega-3 out the window. And also they looked at body weight gain as the primary indicator, outcome variable. And you all know body weight gain in a cancer patient who's on chemotherapy or on any therapy, especially a cachectic patient, a pancreatic patient. It is the worst indicator of outcome of anything. Because it's affected by hydration, it's affected by corticosteroids we use with treatment, and so many other medications. So weight gain is not a good indicator. I mean, I wouldn't be happy even if they gain weight, because that's not a good indicator. So we started to look at the inflammatory pathways, like I said. And this is what we came up with. Our schema was that omega-3 fatty acids downregulate this NF-kappa B, upregulates I-kappa B alpha, which goes hand in hand, accumulates P27, decreases this proteolytic inducing factors, or PIF, and decreases the breakdown of this muscle fiber proteins, and improvement of lean body mass, serum visceral proteins, and functional markers. So this is the schema we came up with, and that was our hypothesis. So we looked at, we took a standardized preparation of omega-3 fatty acids. By the way, over 90% of what's available OTC is not bioavailable of omega-3 fatty acids. So if you're serious about omega-3 fatty acids, Lavazza is the one to order. And we try to spread this word even among our clinicians. Markers of toxicity, we looked at that because we thought if you gave omega-3 4 grams to a cancer patient, we thought diarrhea will result, right? I mean, that's what I thought. So we wanted to definitely monitor markers of toxicity, serum albumin and transferrin. We did an intervention for 6 weeks, so we used albumin as a marker. Skeletal protein status, height, weight, body mass index, mid-arm muscle circumferences. I mean, a DEXA would have been the best in this case, but they were very ill patients, so we didn't want to burden them by taking them to a Lifetime Cancer Center for LCS for doing the DEXA. Nutritional intake, serum cytokines, IL-6 and TNF-alpha are implicated. We looked at K-scale for functional status and physical activity, and it was a 6-week intervention in cancer patients. And what we saw was a very significant result. We saw downregulation of this NF-kappa B in 9 out of 14 patients who completed. It's almost 64% of this group, which is significant in the sense we could start thinking about the molecular target of omega-3 fatty acids. And, you know, we saw, I'm just going to quickly summarize the results. We saw increases in serum protein, both albumin and transferrin over the 6-week period. These were men and women who were identified with stage 1 cancer cachexia. Now we have staging for cachexia, 1, 2, 3, and 4. So we caught them early. It was less than 10% of their body weight loss, which was unplanned. So that was the criteria for inclusion. And we also saw increase in functional markers and increase in physical activity in this population. So, but the weight stabilized. I mean, it didn't have an increase or decrease in weight, although that was not our primary outcome. Every group advised that you should include weight anyway, so we did. So here's another example of a post-treatment trial. And I wanted to recognize Dr. Small, who's in the audience, who's one of our co-investigators. This is a phase 2 clinical trial of what we call CogNutrin, and something we coined. This is cognitive training and a nutritional intervention in treating chemobrain. If anyone saw the ASCO journal that was published today, there's a report of that the breast cancer patients who survive breast cancer experience chemobrain for over 5 years, even after survival. And there again, we thought it was a transient thing. A chemobrain comes, goes away after a while, but it doesn't. And as more significance of a study like this. 22% of the nearly 11 million cancer survivors are breast cancer survivors. Most common complaint from our patients is the chemobrain, a phenomena of cognitive impairment reported in 30 to 75% of patients treated with chemotherapy. It's very common in breast cancer, and we've come to realize that it's also very common among childhood cancer survivors who are now adults. Pretty much childhood cancer survivors with brain tumors are mentally retarded, and we are collaborating with St. Jude's in Nashville, and we are writing a protocol for them to look at chemobrain in childhood cancer survivors who are now adults. I said lasting anywhere from 6 months to 10 years. This has been proven not only by the group from Fred Hutch that was published in ASCO, but by also Dr. Small, Dr. Jacobson, Dr. Jim, and others from Moffitt Cancer Center. So we know that this has a multiple etiology, and I'm sorry this is so busy. I wish I'd done a schema for this one also. But we know that the manifestation is very different. The etiology is still not understood very clearly. It's very similar to cachexia, but we thought this is caused by multiple injuries or multiple insults that a patient endures during the treatment. I mean, even we don't treat patients with one drug anymore. It's always 3 or 4 chemotherapeutic agents. So we thought that since those agents affect multiple pathways, we also have to do a multifaceted intervention. These agents have to have multiple components. They should affect the oxidative stress pathway. They should affect the inflammation pathway. And so we came up with this agent that actually Dr. Bickford at the Aging Studies Group developed for treating early Alzheimer's disease. So when I was working with them, I said, why don't we use the same agent here, but add the anti-inflammatory agent that we know works through the NF-kappa B by downregulating NF-kappa B that we saw in our treatment trial. So we added that agent along with the agent that they had developed to treat early Alzheimer's disease and to reverse that oxidative damage, reverse inflammation. And so we thought that this can work synergistically to facilitate the reduction of the oxidative stress loads of inflammatory cytokines with significant improvement in cognitive health. And in talking to our colleagues at St. Jude's, we also saw that they can actually measure image function, changes in function in the brain with interventions. So they were doing interventions with physical activity and cognitive training, which also our group here does. They do cognitive training, which is like playing video games. That's how I equate it to. That increases memory, increases alertness, increases several of the functions that go to form cognitive function. So we combined all our heads, and now we have a great study looking at the safety and effectiveness of our intervention with cognitive training. And this agent, which is a combination of antioxidants, very potent antioxidants, not derived from vitamins and minerals, but from plant foods, blueberries, strawberries, all grown in our backyard, and for a 6-month period in breast cancer patients at Moffitt, whereas in St. Jude's, we're going to target the leukemia survivors and childhood cancer survivors and evaluate the potential mechanism. Also, this is also one of our aims, and we're also going to look at cytokine panel and looking at inflammatory markers. Again, there has been always a challenge, the cytokine panels, because patients who are getting treatment, you can't do cytokine panels in them because it's all over the place. So these are the things that we are, this is in our pipeline. Isoflavones, we are working with prostate cancer. This is my last slide. Carotenoids, we're looking at, we have a promising study with lycopene in prostate, and I think we'll pursue that one. Green tea polyphenols, we have a huge study similar to isoflavones. Curcumin, we have proposed one in former smokers, and we're also working with the GI group. It looks like a very potent anti-inflammatory as well as an anti-proliferative agent, except you have to swallow 6 pills of yellow powder. We're trying to see if we can get nanoparticles of that so we can make it a reduced amount. So we always think about patient burden. Omega-3 fatty acids and cancer cachexia, we're going to proceed with this. We just got another study funded by Novartis, which is a pharmacological drug targeting protein breakdown. It's a competitor for omega-3, but it's a great thing for us because we're going to be comparing omega-3 to the results of that study. Resveratrol, we proposed that for breast in DCIS. Cognutrin in cancer survivors, and metformin in BRCA1 carriers. So this is in our pipeline. I just wanted to thank my research team. I always say it takes a village, and it really does. This is all our group of, and like I said, it's very important to have that interdisciplinary team approach to what we're doing. And this is only one study. This is the RO1 we have funded looking at catechins. This doesn't include our Cognutrin team, our Cachexia team. Each one looks like this. Thank you. Yes.
Big jars, you see it in the tea bags themselves. Is there any that one should look for?
Most of the green tea preparations that are made by the, Lipton or one of those companies, the bags, they are the best form of green tea. And also, we got the package from the Japanese company that makes our tablet. It actually lets the Japanese and Chinese let the tea sit in hot water for at least a minute. It came with instructions, basically. And that allows the EGCG to really soak in the water that you're drinking. So the more powdery the green tea, the better. And I think the bags are the closest to it. And I would stick to the major companies. I never recommend people buying from very gourmet sources, because nobody's checking the gourmet sources. But people like Lipton and others are under the microscope more.
And then just a comment, when you're talking about your Cognutrin, it reminded me of when they started Gatorade. I remember reading a lot about the trauma that the athletes succumb to because of brain injury or whatever. So I didn't know if you want to change this to positive faith.
Nice. Very nice. Thank you. Brent, we should think about that. Yeah.
Yeah, I have a question. When you were talking about the omega-3 fatty acids, you said that the commercial ones, many of them are not bioavailable. Can you explain that more and why there would be one that actually works and the others?
Yes. The ones that you get over the counter are made from all kinds of fish oils. And the companies that make those don't have any standardization guidelines to follow. Currently, those kind of nutritional supplements, just like the garlic I was talking about, I always tell people, if you want to get rich unethically, go open a supplement industry. Go open a supplement shop. And you can do it in your backyard, pretty much, and encapsulate anything and call it Cognutrin or, whatever you want. So I think the industry is so not monitored that they pretty much do anything. And this was recently published by FDA in Quackery warning that 90%. And why am I saying Lavazza? Lavazza is made by GSK, and I'm not here to promote GSK, but they make a standardized product that's already used for another indication. It's used for hypertriglyceridemia. So it's the same drug, we're just using it for another indication. And that's why I'm saying, because they are, of course, they have deep pockets and you can really sue them. So they're very careful about their ingredients. If it's a other company, they'll just close shop and go and open another shop with lycopene as a supplement or something. So, Tom?
You can buy that over the counter?
Lavazza, no. It has to only by prescription. Yeah.
Are there any of the products available to us that we can buy off the shelves?
As you can see, I already said, I confessed, I'm a snob about this. So I would say we are only in phase 2 clinical trials. Many of us, I think around the country, there are about 4 or 5 large groups very similar to ours that are still working on these agents. And I don't think there's one agent that's up to phase 3 yet. We're doing it very systematically. We had to like clean slate and go back to starting from scratch and doing it very systematically. So I would say the nutrients related to that. And that's the other thing that I keep saying, paint your plate like a painter's palette. The greener, the redder, the yellower your plates are, the better. You're getting all the stuff that I've been talking about. So I think that should be the goal for now. And, many of these are still under investigation. Yeah. Dr. Sellers? Yes.
Well, I have one quick question.
Yes.
I first need to register a concern.
Yes.
That is, if you've been in clinical practice for 33 years, I'm sure you've been violating child labor laws.
Love you, Tom.
My question is, great talk, Nagi.
Thank you.
Very compelling need for chemoprevention, and unfortunately, a lot of people who are interested in this are interested in GI cancer. What can I do about it? You gave some great examples on how these areas might contribute to symptom control, symptom management. But I'm wondering your thoughts. Is there any data that any of these things might actually relate to prolonging life?
Yes.
Or treatment? Because
yes.
suspect that comes up in
yes, exactly. If you think about some of the biological plausibilities that I was talking about, how some of the steroid obesity affects steroid hormonal pathways that increase the risk of cancer. I mean, that puts you in a different profile that increases the prostate cancer risk. In those studies, we argued that whatever is good for prevention is potentially good for survival also, because some of the same pathways may be implicated once the treatment is done and the patient is now free of the tumor or somewhat free of the tumor. They're never going to be complete. I mean, if I was a cancer patient, I would never think I'm completely free of the tumor. But definitely those that work for prevention, if you look at it theoretically, must apply to survival also, in preventing recurrence of the cancer also. And I think we showed that in survival with body composition and body fat distribution, that it affects survival. It was published in the journal Cancer, that we showed that that kind of a body shape also put them at risk for not surviving from cancer. Those that did not have that kind of a body fat distribution, the android distribution, were the ones who survived breast cancer when we looked at them 10 years later. So definitely that's the direction we're going. And even if you think about the cognutrient composition of cognutrient, the anti-inflammatory agents, the antioxidant agents that we're looking at reversing cognitive impairment, that could be used for anti-aging. It has so much promise even in the future. Even the omega-3 fatty acids. Think about Parkinson's and other neuromuscular degenerative diseases. It can